Hi, I'm Dr. Melissa Walsh, board-certified OBGYN and medical director at Pomelo Care. Before joining Pomelo, I was in full-time academic and public health practice for over 12 years at the front lines of New York and Florida. Over my career, I've seen a growing trend in preterm deliveries, cesarean delivery rates, and high-risk pregnancies, especially during the pandemic. COVID worsened the barriers to access and exposed the inadequacies of our healthcare system, especially for our under-resourced and BIPOC communities. Pomelo Care was founded to help bridge these access gaps and address underlying risk factors in maternal and newborn health by holistically supporting patients and their in-person healthcare teams through telemedicine. Before the pandemic, only 1% of medical encounters were by telehealth, which increased to 50% within the first month of the pandemic. The tech was always there, but the traditional medical establishment hadn't had a reason to incorporate it. And soon it became the only option of care access outside of the urgent setting. For my position in FQHC, I saw numerous possibilities: mental health assessment and therapy by video visit, remote blood pressure and symptom monitoring to help patients determine if they should come to the ER or not. Telehealth would allow for 24/7 virtual access to medical professionals, reducing delays in care and saving patients time and exposure. Now that telemedicine is in the mainstream, we have an unprecedented opportunity to get the right care to the right person at the right time. In the US, we're experiencing high and growing rates of maternal complications, comorbidities, and inadequate care. We have a 32% C-section rate nationally, 24% of patients with inadequate prenatal care and therefore unaddressed risk factors, and 50% of our moms who are suffering with depression and anxiety are being left untreated. Among lower income and Black mothers, these outcomes are even worse. Black mothers have 3 times the risk of maternal mortality, an atrocity that demands more action. Not only are these negative health outcomes bad for moms and babies, but they're also extremely expensive for our healthcare system. NICU stays cost an average of $6,000 a day, and 10% of babies are being born premature, and many of them are being admitted to the NICU. Untreated maternal depression and anxiety cost $32,000 per 5 years for dyad pair, and in 2017, this amounted to $14 billion. The gaps and challenges exist across all parts of our healthcare system. From the patient perspective, the system is difficult to navigate and access, especially during prenatal and postpartum care. When patients need a lot more care due to comorbidities or social determinants of health, they are confronted by the silos of our system. For clinicians and their staff, the challenge is helping their patients get what they need while not burning themselves out, commonly dealing with limited resources and limited capacity for care coordination. And payers, including government and health plans, see the rising costs and worsening outcomes, but generally have to grapple with the current limitations of the system's infrastructure to achieve targets in a way that's acceptable to stakeholders. So this leads us back to the priorities of improving access, equity, capacity, and outcomes. But how can we do all of that given this complexity, and what is the right care? Likely unsurprising to anyone in this room, the causes of these poor and equitable pregnancy outcomes and high costs fall into 3 buckets: medical, behavioral, and social. Across these 3 domains, we have known but underutilized evidence-based interventions. This work falls into what Maternal Health Learning and Innovation Center is doing to address these challenges. In the next slides, I'll review what we can do to build on this cumulative knowledge. These are the tactics that we're using to achieve the goals that we all agree need to be done to move the needle on outcomes and costs. We should be taking a pop health approach to pregnancy care, implementing evidence-based interventions in a holistic way to improve outcomes across all of the domains, and leverage mainstream tool of telemedicine to fill gaps experienced by all stakeholders in the healthcare system. Let's dive a little deeper into each of these tactics. So we take the approach that maternity care should be more like primary care. In primary care, we know a certain percent of patients will develop a disease, so we monitor for the risk factors and implement wellness programs to prevent these diseases. Unfortunately, this doesn't happen in pregnancy because the current prenatal care model is more reactive than preventative and compounded by staff and resource limitations. So what could be a better approach? Looking back at the idea of population health, what if we looked at pregnancy impacting risk factors and leaned in on implementing evidence-based interventions earlier? By doing so, we will really leverage the increased motivation people have for healthier behaviors in pregnancy to make a difference. So here's what a population health evidence-based approach plan might look like. It maps each risk factor to a specific intervention known to improve outcomes in clinical trials. Risk factors for hypertension, we get that person into intensive dietary and medication management. If there are risk factors for postpartum depression, we can do early screening, therapy, and planning for a sometimes difficult postpartum period. So if you're going to be able to offer interventions for risk factors during pregnancy rather than just diagnoses, it means we need to evolve the prenatal care model to incorporate easy to access holistic care. There's a huge wasted opportunity between routine prenatal visits for initiating these preventative strategies. And by identifying risk factors through screening and offering comprehensive care between visits, we can make a very big impact. By facilitating easy access to the healthcare system, we can implement this holistic model of evidence-based interventions that are complementary to the traditional in-person care. Let's look at an example about diabetes. So what does this actually look like? I'm going to walk you through briefly a story about a patient that we are fortunate enough to work with. Her name is Shelley. She was becoming a first-time mom at 43 after trying to conceive for many years. Like many pregnant people, she experienced some unexpected health conditions, such as gallstones, which sent her to the ER, and she was told to cut out all fat from her diet. That left her confused and very limited in what she could eat. On top of that, she knew that she was at risk for gestational diabetes, so she turned to Dr. Google, but quickly became overwhelmed and hit dead ends, finding advice that applied to her and her lifestyle. Many patients will be in this situation, and what is there to do? Luckily for Shelley, she did not develop gestational diabetes, and she ended up having a healthy baby boy. She was able to work closely with our Pomelo care team to develop a personalized plan by including regular appointments with our dietitian to do meal planning early in the pregnancy from the first trimester when her risk factors had been identified. She was also able to work with our behavioral health specialist to help navigate the ups and downs of pregnancy and meet with our lactation specialist to plan for breastfeeding goals before birth. We were there to support Shelley every step of the way and answer all of her questions, big and small. But setting up a system like this is difficult in our current OB practice setting. And as an OBGYN, I think I can speak for many of my public health colleagues to say that we would love to offer these kind of services, and we know that they're important, but it's just not feasible nor are the resources there to make that happen. Which brings me to a third suggestion, using telemedicine to extend in-person care. It can allow for 24/7 access to highly skilled physicians, and it can be designed to fill all of the gaps that we talked about. For patients, they can get quick, easy access to information and personalized care. For providers, it unburdens office staff, frees up appointments, and for payers, it helps them know that there's a clinical partner that maximizes the goals of their benefits program. At Pomelo, we operationalize addressing poor outcomes and high costs across the three domains, using evidence-based strategies as mentioned before. Our fundamental approach is to make it easy for patients to access us using all channels, chatting through secure app, SMS, audio, and video. We meet the need and always say yes to being able to help people. And if we can't deliver a service ourselves, we walk with them to navigate the healthcare system together. We also work with our plan and community partners to know exactly what programs are available to patients and help them to access. We staff a superb clinical team that is employed by us, not a marketplace. We wrap around the patient and their in-person provider. We also use the primary nursing model to help with continuity of care and bring other clinicians into the care team as needed to bring the right person to the right care at the right time. And this episode goes from planning the pregnancy all up the way into the first year for mom and baby. We're designed to be supplemental to the clinical care that is happening in person. We partner with providers and payers. We can also partner with FQHCs, expanding off-hours care so they can prioritize their resources and know that their patients are well supported between visits. We align ourselves with the same goals of improved outcomes, controlled costs, and the same metrics, taking accountability for the patients we serve. Crucially, we have focused on building a solution that pays for itself through savings to payers. The service remains free to providers and patients to ensure we are not adding to the socioeconomic barriers that fuels the current crisis to begin with. Thank you for your time, and feel free to reach out to us for any information that you need. Thank you.